And I thought, okay, let's define HBR, high bleeding risk. So I went to them, the ERIC HBR focus group, and asked them, what do you mean by high bleeding risk? And they told me, yes, if your patient fulfills the one major criteria or two minor criteria, your patient is high bleeding risk. I said, what are those criteria? And they said, okay, go by this. You see, the light blue are the minor criteria, the dark blue are the major criteria. It is too confusing for me. I said, okay, let's go with the headings. Age, renal disease, liver disease, active cancer, anemia, low platelet count, stroke and other brain mischiefs, bleeding diathesis, prior bleeding or transfusion, oral anticoagulant, we just heard, NSAIDs and steroids, and planned surgery on DAPT. Isn't it a bit too complicated? More complicated than a real episode of bleeding, actually. So I thought, okay, just leave it on the slides. So then I went to what are the stents going to do with this high bleeding risk patient? And I went to ESC 2017, a bit old, but if you find at the top, device used, DES or BMS or DCB, doesn't matter. It's absolutely irrelevant while deciding your antiplatelet type and duration and SAPT or DAPT. Only BRS has got something to do as a stent as a driving phenomenon. Otherwise, it depends on whether the patient is high or low bleeding risk or whether the patient is acute or chronic setup. These two criteria only. Stent has got nothing to do, but stent has got three things. It has got a scaffolding, it has got a drug, it has got polymers. So people thought, okay, if we do away with one of those, we might reduce the duration of antiplatelet. We'll reduce the polymer or get rid of the polymer, we'll change the drug, or we'll change even the scaffolding, which will vanish. And let's see what happens. So this is the more recent of the guidelines, both from America and Europe. And again, you see the stent really does not matter over here. They are all drug-eluting stent in PCI patient. Only matters whether the patient is high bleeding risk or not high bleeding risk. But optimal DAPT duration, as you see, if you see on the right side, there are two, the score. One is the precise DAPT score, which is done on the day or on the table while you are doing the PCI. And do you see the stent, mention of stent over there, of the 5 criteria? No. Stent does not feature in deciding on day 1. What does it matter? Yes, at 12 months, when you are doing the DAPT score, there you first see the mention of stent. You see the length of the stent, and you see the stent diameter, and you see paclitaxel is mentioned. If there is paclitaxel, you are more thrombogenic, you give more antiplatelet. So that is the first time we see that stent comes into picture in decision making. But thereafter, flood of industry-sponsored trials came. Inclusion criteria for high bleeding risk trials, they had lot of criteria. And you see at the bottom, what was the duration of DAPT for them? 1 month, 1 to 6 months, even 2 weeks. 3 months, 1 month, and so on. 2 weeks is the COBRA reduced stent. So everybody is claiming, my stent is not thrombogenic at all, and you don't need to give too much of antiplatelet. Maybe you don't do any medicine. My stent will be there without any thrombosis. I don't know. Days will come. But at the moment, we know that 1 month DAPT, the Biofreedom and Endeavor have proved their guts significantly better than BMS for both safety and efficacy, and 1 or 6 months of DAPT by everolimus Synergy stent significantly better than BMS for MES. So the traditional idea that MES is reduced or thrombosis is reduced while you use the BMS and avoid the drug altogether is perhaps not valid in 2022. Perhaps BMS is not so good in a thrombogenic milieu. Even DES can be better than BMS, both for thrombogenic milieu as well as for high bleeding risk patients. So that's a lot of studies came. I won't bother you or bore you with all these trial details, but trials of stent for patient at HBR on short DAPT and on, you see the single antiplatelet versus dual antiplatelet. You see the leaders for 1 month, senior for 1 to 6 months, Onyx 1 for 1 month, leaders free for even less than 1 month, Onyx 1 clear, and so on. And if you see the right side, most of them are either non-inferior or superior with shorter antiplatelet duration. Some results are, of course, pending. And if you see even trials of short DAPT for patient using the same stent, say Zymes, 3 months versus Zymes 12 months, and you see it is non-inferior. Similarly, master DAPT, 1 month versus 12 month, non-inferior. And trials of stent and short DAPT for different stent, evolve short DAPT against other DES and Cobra reduce against other DES, they are showing that with my stent, you do not give antiplatelet. I mean, give casually for a month or so, or you can forget it, something like that. That is their attitude. So maybe they are right, but you see, they are sacrificing the scaffold by giving bioabsorbable. They are sacrificing the polymer by giving polymer free, but they are not sacrificing the drug. They are changing the drug because drug free is no longer sponsored, it's orphan. Maybe that is the reason, I don't know. So the optimized randomized, you see the clinical non-inferiority of 3 months versus 12 months with Jattoralimus, and the outcome is as good, if not better. Durable polymer JDS and BMS, and again, the results are pretty comparable. And if you see 3 or 1 month DAPT in HBR patient undergoing PCI with Zymes, as I already mentioned, they are very comparable. There is no extra thrombosis, but less bleeding, of course, and which is so suitable for HBR patients. Onyx 1 clear with HBR treated with a Zetoralimus with 1 month. Those with single vessel disease had favorable 12-month ischemic and bleeding outcome, which are comparable with those patients with larger caliber vessel, so small vessel disease, sorry, not single, small vessel disease. So polymer-based or polymer-free stent in patients at high bleeding risk, Onyx 1. And if you see, you cannot really separate the curves too much. So you can do away with the polymers as far as efficacy is concerned at 1 year. Polymer-based, again, Onyx 1, you see the bleeding risk, again, they are the same, secondary outcomes. So polymer-based or polymer-free stent, Onyx 1 in high bleeding risk patient, you can really do away with longer stents by only 2 weeks or maybe up to a month without, by sacrificing the polymer. And then the high bleeding risk with polymer-free drug-coated coronary stent, the LF2 study, again showing the same results that actually you can do away with polymers with reduced antiplatelet duration. But it may not be relevant to mention the drug-eluting balloon in this setup. And again, we see the same type of recommendation. And then also the small artery, coronary artery. This is very recent, published only this year, that basket small 2 trial, drug-coated balloon. And again, in high bleeding risk patient, they are doing very well without any antiplatelet support for a long time. So primary result of evolved short DAPT, I have got 1 minute, I'll finish before that. If you see, we have got 4 set of patient, high ischemic, low bleeding, high ischemic, high bleeding, low ischemic, low bleeding, and low ischemic, high bleeding. So overall risk of adverse event goes on as we go up the ladder. So I conclude, my friends, high bleeding risk patient constitute a sizable, heterogeneous, and growing proportion of PCI candidate, but until recently they have been excluded in trials. Use of BMS is no longer justified. Several ongoing trials are assessing other drug-eluting with short or ultra-short DAPT, while shortened DAPT, de-escalation, and monotherapy have all been evaluated, mostly in non-HBR. The optimal antithrombotic regime for individual HBR patient is not yet fully defined. There are lots of pioneers over here. I hope they will come up with better answer in next year. Thank you.